All right. Hello, my name is Mark Dean, and I've got some good friends of mine here that have kind of helped pioneer the eustachian tube dysfunction and treatment options that we have today. And, I'm going to lean to Holger Sudoff here, Martin Moyer, and Dennis Poe. And each one of them made really significant contributions to this field. And so we're going to get a chance today to kind of hear the history and what we're doing today and kind of where we think this is going in the future. And so I'll kind of start with Holger to talk about the history and kind of the reason we need to be looking into this and why it was a problem and what they've done in the past. And then we'll kind of segue into Dennis Poe and some of the early work he did of really figuring out where the problem was, and then back to how we've kind of treating it today.
Great. Well, thank you, Mark. I'm going to speak about the history of eustachian tube surgery, early attempts and failures in surgery. And it was really an interesting journey because when we started doing the first balloon dilation, I was pretty much aware and I was taught in the sense that you never touch the eustachian tube. Whatever you do, you make it worse. So I was a junior doctor in Germany, and I tried my really best in order to investigate the situation. And we know from the past medical history that the eustachian tube was firstly described probably in Sparta in 400 before Christ. There was long history before it was actually discovered that it's connected to middle ear disease. And what we've seen with Alan Politzer, who actually was the first one to connect eustachian tube problems to middle ear disease, it was a huge journey. There were Scottish and British military surgeons who tried to puncture the eustachian tube. There were lethal incidents in the history of eustachian tube surgery by opening up accidentally the internal carotid artery. And it hasn't led to anything because the technology at that time was not simply able and capable of dealing with the problems of eustachian tube. So, with the history and the involvement, we needed a certain level of technology to be able to do that, and the use of microscopes, endoscopes of the past medical history actually established the situation that we are in now, where we're able to treat all the different eustachian tube entities, and we're still on a learning curve. So I think it was a really interesting story so far to see the early attempts of eustachian tube, and this led to a long-term dogma: don't touch the eustachian tube. And when I touched it for the first time, I rang up two world authorities in otology and asked them, I want to try that. What can I expect? And he said, why do you want to ruin your reputation with that technique? You make it worse, you way endanger the patient. But I think there have been hundreds, thousands of patients being treated with balloon dilation and eustachian tube surgery. So I think we are on a good track, and we've learned from our past medical history.
And I think that, so in the past, one of the reasons I believe everybody had a lot of trouble is that they always thought the disease was at the bony isthmus. And so everybody was trying to widen this bony structure into making it larger to let things go. And I think that's really where, Dennis, your work really came in the late 90s, if you want to kind of describe your epiphany with the slow-mo and everything else of just watching it and how we kind of came to being able to operate on that eustachian tube without having trouble and not getting into the carotid of that bony isthmus.
Well, so thank you for that beautiful introduction there, Holger. So as Professor Sudoff has just told us, this was, I shared the same information in my training. Don't even think of touching the eustachian tube. It will scar shut, and you'll just get into trouble, or you'll cause a complication. And patients have died because the internal carotid artery is in close approximation, shares a wall, sometimes even dehiscent with the bony portion of the eustachian tube. So these surgical interventions actually did have some catastrophic outcomes trying to operate on the bony isthmus. And so our team similarly wanted to begin to investigate this. Why has this been such a problem? How can we avoid these complications? And we started looking endoscopically. So some pioneers early on with microendoscopes where this is Hopp's group in Germany and Shay's group in France, started looking with microendoscopes up the nose, up the orifice of the Eustachian tube, and realizing that the bony portion could actually be completely patent, even when there's a middle ear effusion, raising the question, could it possibly be a problem in the cartilaginous portion? And so we started looking at that with more sophisticated, larger endoscopes, trying to look down the lumen. And previous reports all said, you can't learn anything from looking at the orifice of the Eustachian tube. And that was our early experience also. We took a lot of videos and extremely frustrated. We weren't learning anything until one day I just accidentally put the video into slow motion. And then I saw how it was opening and closing in slow motion in a beautiful series of steps with the levator elevating the floor and medially rotating the torus, and then the membranous wall being pulled in a lateral direction to open the valve by the tensor muscle. This 1-2 effect turned out to be very consistent, and we realized it's a valve. It's not a narrow pipe. It's a valve at the cartilaginous Eustachian tube. We then studied that in slow motion, a number of patients, realizing there's all sorts of pathology, and it's inflammatory pathology. We can treat that. So early attempts, there was a Swiss surgeon, Kojowski, who was the first to try laser treatment, cauterizing some portions of the mucosa on the cartilaginous wall of the Eustachian tube. And the results were modest but consistent, and showing that we could reduce inflammation, which was a surprise. He was thinking in terms of widening the lumen to make it easier to open. But a side effect was there was a greater loss of inflammation than the area that was actually treated, which was relatively small, really just near the orifice. So we explored all sorts of different techniques, cautery, radiofrequency, deeper lasers, everything we could do to try to get a little bit bigger field. And then along came the sinus balloons, and the sinus company, one sinus company was chasing after me saying, you should try a balloon in the Eustachian tube. That would take care of it. And of course I could think of lots of reasons why that shouldn't help. It's going to flex the cartilage. It's not going to break bone like it does in the sinuses. So they were harassing me so much. I actually went to the lab with them to prove that this was a bad idea. We shouldn't do this. And darn if in the cadaver lab, it was behaving much better than we would have expected. So we had to try it on patients. And sure enough, it was far more successful than the lasers and the other things that we were doing. And it was really significantly reducing inflammation. And so that's the beginning of the story. It's turning out to be an inflammatory disorder in most of these cases of obstructive Eustachian tube disease. And we know how to treat inflammation. We try to treat it medically. And now we've got a device that will help treat it. So we studied the histopathology of that and found that there's really adenoid-like tissue that travels deep into the lumen of the Eustachian tube. And this balloon reaches that. And it turns out when you take biopsies after balloon dilation, weeks later, it looks like you've done an adenoidectomy. It eliminates the lymphoid nodules and restores normal pseudocolumnar epithelium. So we have a tool which has been very effective in treating inflammation adenoid-like tissue that's gotten down into the lumen.
I think you published your first study in 2010 and you were in 2011. So when you really think about the history of medicine, it's really only been about 15, 16 years since we've really been doing this in patients. And, you know, I've been fortunate enough to be involved in the randomized controlled trial that in the US was showing objective normalization and success. And we really did these in adults first. And so, you know, one of the things that I think in Europe, you guys started in pediatrics a little bit sooner, about the same time you guys were using it first, but you kind of stayed above 8 mainly because the Eustachian tube anatomy is really evolves from birth until about 8 years old. Once you're 8 years old, it's the same length, size, function of an adult. The nose does still continue to grow, so there's a little bit of evolution in the airflow and just the ease of access. But after 8, the tissue responds and is the same size otherwise. So I think most people started at 8. Although you might be able to speak better than me because it was in Germany as well with the same balloon that they were doing kids pretty much about the same time, correct?
Yeah. We started with that in kids because, of course, the composition of the Eustachian tube is different. So the dimension, if you compare the bony part and the ossification of the temporal bone starts, and the cartilaginous portion is much longer, and the angulation of as you know, of the Eustachian tube is horizontal in children, and this is probably the main reason why the middle is more prone to serous otitis media. And I think the dimensions of the balloon that we initially established allowed us to do balloon dilation in children. And it's probably the most interesting group to address because you can prevent all the sequelae of repeated infections, maybe the development of cholesteatoma. So I think in children, you have the chance to do kind of preventive medicine with balloon dilation. And when we started with that, we had a highly selected patient group. All of them had at least 2 long-term grommets, and we've still seen a major improvement of their condition. And I think that was quite reassuring because if you do that in adults and you're hugely successful with patients that face ambient pressure problems like divers or flight attendants or pilots. But if you have a long-term history of destructive middle ear disease like cholesteatoma, and then you restore ventilation, the success rate is of course not as high as if you would do that in a preventive setting, and you are able to overcome probably the sequelae of chronic infection of the ear. And the pediatric group, and we still need randomized controlled studies. We're on a learning curve with that, but that's probably the main group to address because then you can really benefit to the patient in the earlier age. And maybe you can skip a lot of grommets. And so I think it's a major aim to look for children.
Again, you started, when did you start doing children?
We started out in children some years ago, but not as early as the Germans. But now we are actually doing a randomized control study on children down to 2 years of age, and we look to do they have to have another grommet or not? So grommet one side, balloon on the other side, and let's see if it works or not. So far we have a few patients, and the preliminary results are good. So it's a very interesting study. And in Denmark, like Netherlands, we do grommets on 25% of all children. So it's really enormous. Mm-hmm. Denmark is a very small country, and we're only 6 million people, but we do grommets in 30,000 children. So it's quite a lot, and it's a massive social economic issue as well. So we see these patients coming back and forth to the ENT practitioner, and with sick leave, and families are really struggling with these kids. And if we show that this could be a preventive tool, I think we have a very good case.
You know, I heard about the Germans doing it in about 2012, and I thought it was a great idea, but I just gotten out of residency, and I'd learned from my mentor that showed me Dennis's videos, thought it was great. So I started doing it in kids, and after talking to Dennis, I realized not everyone was doing it. So he was very helpful, and we actually followed those patients for up to 10 years. And he got his fellows to help do a cross-match study to try to justify, to see kind of what would happen for both ancillary procedures, sex, age, all the other kind of match variables. And with everybody had one grommet. And all of my patients had not had any tubes at the time of the procedure. So it was just the balloon. And so it was 20 patients in each group. And we ended up showing that over actually going out to 6 years, that 90% of patients that had a balloon dilation did not need another procedure, whereas 50% that had already had one grommet and needed another grommet within 2 years, actually. And so I think you repeated the study, didn't you, Dennis, with your own data?
We had
well?
we had a cohort of 26 and matched controls in another group of 26, all of whom had 2 or more grommets prior, and nearly all of them adenoidectomy. And here they are looking at a third grommet or more. And so we had very similar results with a 2-year follow-up. When you look at those survival Kaplan-Meier curves, we had an enormously different, statistically significant difference favoring the balloon for the long-term survival versus the grommets, where they repeatedly had to a very high prevalence of needing more tubes, or incidence of needing more tubes. So it was almost identical Kaplan-Meier curves compared to your study.
And then after that, we actually did a pooled analysis of about 6 sites, I think it was, over 400 patients, where they basically looked at whether they need another procedure or not. And those numbers appeared to be equivalent and the same. And then that's actually what led to the FDA approval for, at least in the US, down to 8 years old, for at least one of the balloons in the US. Obviously, a lot more is going to need to be done. This kind of maybe segues a little bit into the future conversation of under 8 years old, since it's not adult anatomy. We listened to lectures today about, through the mouth, different techniques for access, adenoid tissue, different causes of inflammation. So there's still a lot to learn, I think, in the younger population of pediatrics, and exactly who does it. Do we need to hold it for 2 minutes? Is there a risk of patulous? Is it the size of the balloon that's a problem? Is it the time you hold it? Where does that come in? I think one other big innovation that's kind of happened in the last 5 years is really trying to move this to the office. Tubes are done, at least in adults, traditionally in the office, but the balloon was kind of started off in the OR, partly because of just the FDA and the studies. So kind of moving it into the office, and surprisingly, it's been more of a challenge, I think, because some of the innovation and the access to it and how you do it, than even the sinus procedures and things like that. And so I think when did you start doing local?
I think I started out in maybe 2014 doing local stuff. Like everyone else, I'm fighting for OR time, and it's hard to justify that. Can I do this balloon case? Or you have a cancer case? Well, okay, I see. So, and I got annoyed. I could not treat my patients. So I thought, it's a 2-minute procedure, and how hard could it be? So we started out, and we had some big Viking fellows coming in, and we did some sprays in the nose, and we did the procedure. It was quite painful, but they managed. And then it gradually evolved to what we do today. And in Copenhagen alone, I've done more than 1,000 cases in local anesthesia only, no cheating with propofol. So they come in, we do the injections, we do the procedure, they walk home straight away. It's very straightforward procedure, minimal amount of pain, a little bit of discomfort. In my case, we have more than 89 will say, I can do this procedure again if we wanted to, in local anesthesia. So it's absolutely doable.
I have a question for you about your protocol, because I've been interested to follow how you've modified your anesthesia protocol.
Yeah.
At one point, you were using just topicals, and then
Yes.
you went back to using some injectables. Could you talk a little about that?
Yes. So I think topical is a great option. In my series, I do get a little bit higher pain score than the injections, and also when you do the injections, the procedure is significantly faster. So my patient, basically, they come in, we get a little bit of sedative, like a benzodiazepine an hour before, and we do some pledges in the nose, and then just 1 or 2 injections, we do the procedure, patient walks away. So this procedure is done within 20 minutes from arrival to discharge. If you use topical, you will use some more time, but it's absolutely doable.
So Mark, your
it's very efficient.
What?
your protocol, you don't use any injections, is that
I
right?
don't, and the biggest reason, probably the biggest reason I don't was because when I first started doing it, it would always annoy me when there would be blood. Like if you do an injection and they're a little bit vascular or they get some stuff, I was always right where I wanted to be with the Eustachian tube. That a drop of blood would fall on the scope, pull it out, and get in. Because again, one of the things we probably should talk about is visualization, zero versus angled scopes and things, but it was, as I was learning the technique, I found that it was just easier to sit in. And again, for me, I'd also a lot of times would do it in between patients. So it was easier to let the topical anesthetic just sit there. So if I went a little bit longer, it didn't start to wear off. There wasn't those same issues. The other thing though that I do different and why I probably don't need the injections is, as I've looked at a lot of the neural pathways of both the ear and the nasopharynx, all my patients that had pain, because I was a lot like Martin, when we first started doing this, we had a lot of, it was doable, but it was kind of like tube doable. They're squirming around, but they didn't grab your hand, so they tolerated it. And so I did move it to the OR for a while and then moved back. And it was all of the pain was mainly with insertion and dilation. So really that release of that eardrum. So I was dilating, I was numbing up the basically the drum, so that way you're not sensing that movement, and also you've got the branch of 9, the tympanic nerve that's innervating the inner part of the eardrum is also getting numbed up by the drops I put in the ear. And whereas for Martin was actually injecting into the SPG and getting the pharyngeal branch going up into the Eustachian tube, and he's actually numbing it up from the other side. So I think that my takeaway of actually watching Martin's technique was what really makes it relatively pain-free is addressing the middle ear mucosa and the drum, whether you're doing it from the SPG injections or the topical side. It really just, but when I don't do that, now, if they have a tube or if I do a myrigotomy, they don't have any trouble. Like I can do that with topical without doing the eardrum, and they don't have any trouble. It's just when there's an intact drum.
Yeah.
I actually learned that from your paper when you did the cochlear implant study. Like you did the pressure, you measured the pressure in the cochlear implant patients. I mean, it's a lot of pressure that gets into the middle ear, not enough to rupture something, but enough to truly, if you're at negative 400 or negative 350, and you all of a sudden go to positive 100, I mean, you've got a big pressure differential in that ear that can be quite uncomfortable.
And that's also what you need to say to the patients, that when you introduce the catheter, that's when the pain will be there if you have some. And when you inflate the balloon, you will have some discomfort as well. But the time when the balloon is sitting for the 2 minutes, rarely any discomfort, any pain. So it's a matter of seconds. And I think there's a shift when you go to your dentist, you accept a little bit of pain. So this is, I'd say, why couldn't we accept this a little bit of pain for a procedure, maybe in just a few seconds? I think it's manageable, absolutely.
Yeah, there was a paper out of Finland, Lukainen, who actually looked at that, studied the pain, and found the same thing, that it was actually the insertion is what's most painful. And I did a couple of patients looking with an endoscope in the ear so we could see with the tympanic membrane as we were introducing with a separate endoscope the catheter, and actually it was ballooning it out. It was causing some positive pressure as this mucosal, probably a mucosal wave. The mucosa is building up in front and in front of the tip of the catheter as you're pushing it up. It's like a plunger effect. Even though most of these balloon catheters have a lumen to try to vent that pressure, but there's that mucosal wave that gets pushed up, apparently is lateralizing and stretching the tympanic membrane. Actually, Holger, with the Spiegel device, it's so much smaller. Have you ever looked at that? Do you get the same?
The width of the catheter matters to some extent. I think the compression of the mucosa, if you look at the Clarent device with a width of, I think, 5 or 7 millimeters, That's different to the spigot and ties device. And I think the pressure you apply, if you have like 12 bars, you have much more pressure you apply to the underlying mucosa. And I think that's a little bit less as compared, but I don't have any head-to-head analysis. So I think it's just a guess. But at least in my practice, the patients don't complain too much about pain.
Yeah, are you doing over local now?
Well, I do that very rarely, and I have limited experience. When I did my first case in Denmark, in Odense, I tried to do balloon dilation because two really strong Danish fishermen said, well, you can do that. And they were so upset after the procedure that I stopped doing that for a while. And now with what I've learned from Mark and Martin, I think I'm much more confident doing that now. And the spigot and ties as the dimensions are smaller, the balloon is probably a little bit more applicable to that. And the pressure inside is less. It's 12 compared to 10 bars. I'm not sure if that really makes a difference.
I don't think it does.
But
so I use both. I use both the big balloon and the small balloon, and I don't see any difference at all in pain perception. So it's mainly, as we talked about, is the insertion of the catheter while it's not inflated, and then you inflate, a little bit of discomfort, and then it's all over.
My experience.
Yeah.
With all the different balloons.
Yeah.
And when you talk about different sizes of balloons, that's always, I think it's kind of the European versus American bias of what we learned with the sinus balloons. I'd always use the 6 millimeter balloon, and that was all my data. And one of the things that we Martin and I actually did is to kind of look at the pediatric stuff. He had kept similar patients to mine, or data to mine. So we actually compared the children that had gotten dilated with the 3.5 millimeter balloon versus in my case, it had got dilated with a 6 millimeter balloon. And interestingly, the success rate, so people that normalized were identical. I mean, almost within the same number. Like, I mean, it wasn't even statistic, it was almost identical. The difference was with the 3.5 balloon, there was no conversion of type B to type C. It either went to type A or it stayed at type B, and they had to put a grommet in. Whereas for in my group, there was only one that didn't convert to a type C. So their hearing did improve, and they didn't necessarily need another procedure. They were still had some degree of eustachian tube dysfunction, but the number wasn't statistically significant, and we'd only did 50 each. So it wasn't, I mean, it wasn't statistically different between who failed and who succeeded, but the in between, it looked like there might be a trend with numbers. So that may be where the balloon matters.
We also saw a little bit, the big balloon was a little bit faster
Yeah,
recovery rate.
it was a faster recovery rate too. But that might also go to what you're finding, Dennis, in that study you did with patulous, where people were seeing more patulous with a bigger balloon. If there's less disease and you're using a bigger balloon, you may be moving that tissue and reducing that inflammation more based off volume than it is actual pressure.
Mm-hmm. Yeah, well, that's all of these parameters, the size of the balloon, the diameter of the catheter, the pressure used, the duration, none of this has actually been studied comparatively. So we really have a need for both probably animal work as well as clinical trials.
What do you guys think are so that kind of brings us where we are today in I guess the one other thing that has kind of been out in the literature a little bit is the kind of doing it with tympanoplasties, ear procedures, middle ear approaches. I know you and I, Dennis, have looked at doing middle ear approaches, and they can be done safely, but they need to be done under visualization and techniques to make sure you're actually not entering into a false passage, getting into the bone where with a microscope, they had gotten into some of the carotid or the petrosal canal. So if you are going to ever try to go through the middle ear, you really need to be visualizing it, which you and I found to be easier with the endoscope. And I think that may be a consideration in the future as people are doing more tympanoplasties or ear work at the same time. So you're not really also causing nasal inflammation as we go through the same time as you're doing ear surgery.
Yeah, so you're talking about a cadaver study that we did, trying
Correct.
to look at a safe means for introducing the balloon during a tympanoplasty through the ear, so you don't have to have a separate setup, passing it through the bony portion to dilate the cartilaginous portion. And we blew up the balloon in the nasopharynx and then distracted it back, partially inflated, so we knew we weren't going to go through the isthmus, and then we blew it up. And I know you've done some clinical patients with that. I have not, but I believe we talked about always doing a scan first to make sure there's no dehiscent carotid before doing that, right?
Absolutely. Yeah, no, always. I actually, ironically, I don't feel like you need a CT scan anymore for if you're doing a nasal traditional balloon dilation, but I have gotten to where I've seen so many comorbidities with superior canal dehiscence or some atypical anatomy, things like that, that I actually do get CT scans a lot more, not to evaluate for dehiscence, but just other pathologies that are affecting it. But yes, I agree. Always get a CT scan prior to anything with the middle ear and anywhere around that eustachian tube.
Yeah, so when you're talking about chronic ear disease, there's a higher prevalence of chronic ear disease affecting the bony portion of the eustachian tube as well. And we've, Muaz Tarabishi's talked a lot about that. And he's done some dilations in the bony portion very carefully, endoscopically. We have to be careful about not bending the balloon catheter, because if it kinks, it could actually bump into the ossicles, malleus. So some words of caution of that is keep your balloon catheter in view of your endoscope. And of course, you don't want to hit the ossicles with your endoscope either. Yeah, Juha Silvola very early on found that about 10% of the cases of obstructive eustachian tube dysfunction in our series, our combined series, about 10% actually had a problem in the bony portion as well. And obviously, conventional balloon technique's not going to reach that. So we can talk about that later, is how to address the bony portion as a future direction.
And I think that's, kind of where we're at this stage. I mean, I guess I'll probably defer to you, Dennis, to kind of summarize the state of where we are now. But I think that, at least in the US, that balloon dilation of the eustachian tube has been proven in multiple randomized controlled trials. It is accepted by pretty much all insurers and payers at this point. And there are clinical guidelines for when it's appropriate and not. And I think one of the things that I always try to stress, because one of the questions that I think that people still ask is, do I do a myringotomy at the same time or not? I've actually gotten away from that. I know that a lot of people tend to, because they're afraid of, what if it blocks up? And there's been some studies out of China and other things. One of the things that got me away from doing it, and I think we forget about this, is tubes are not that safe. Like, really, when you think about it, when tubes first came out in the 50s, there was barely penicillin as an antibiotic. Like, I mean, you had streptomycin and that's about it. So an ear infection, I mean, your comparison was abscess, death, facial nerve palsy, or tube. I mean, compared to that, the tube's real safe. And we've done so many of them over the years, but there's a 2% risk of perforation just with a tiny tube or a short-term tube. Long tube term, you're up to 16%. That means another trip back, tympanoplasty, 0.1% risk of cholesteatoma. I think I've seen multiple studies that 50% of people have over 5 decibels of hearing loss just from the scar and the scarring of the tympanic membrane. And then when you think about avoiding antibiotics, or physicians, is why we put tubes in, they've actually shown 30% increase in otorrhea with topical antibiotic drops, which when done by an ENT, a pediatrician will give them oral most times. And then it doubles the number of visits they see their pediatrician for.
Correct.
So it's actually more costly to put a tube in than not. So I started not doing it to avoid that.
Yeah. So there's a Danish study recently published. So it was a 4% rate of a permanent perforation in kids. And the social economic cost of having a tube was almost $1,000 a year just for having a tube, because all of the visits to the ENT. So this is a Denmark of the Danish population and the Danish numbers, but I suspect it will be more than double in US just for having the tube.
And you don't think about that. And so like what I've actually got, that's one of the reasons I early on got away from doing it, because if I'm going to do the balloon and it really does work, then I don't want to violate the Eustachian tube and then, or the ear and lose all the benefits of the balloon. And so I think that'll be something that will evolve over time, but it really, if you're looking at a cost savings for the balloon and paying more for the device up front versus, again, $1,000 a year extra, well, you've just equaled it out right there without even having to go to another procedure or anything like that.
And then you have 30,000 pediatric cases, and 4% of those need another surgery, another sick leave, and another complication, full anesthesia, and so forth. So you need to add up all the numbers, I think, to have the full picture.
So I think to where Holger kind of talked about early on was that, you know, this is really the most impactful, even if it's not the cholesteatomas or the OCRs or all that destructive disease, just really the, you know, one of the things that I found in my practice that was the biggest, I guess you could say, seller of the procedure, the convincer, was they're like, so when can they swim? Tomorrow? Like, we didn't do anything in the tube. Be like, you can go today. I don't care. But if you think about it, I mean, in a kid, the social situations of being in water and being able to control all that also matter. And so I think it is, I mean, I've always found myself very fortunate to have gotten involved with this early on, because I really think this procedure, when you really think about what it's done, is it will pretty much eradicate an entire field of surgery of chronic ear disease over time. I mean, there'll be pockets of it, but it will be the main part of it once we've really understood what we're doing.
So that's actually a major issue in Denmark. Every summertime, all the kids go swimming in pools and stuff, and they come back with effusion and infections, and the parents are trying all sorts of things, headbands and silicones and all stuff. Nothing works. We just see a skyrocket of infections during summertime with all the tubes, and so yeah.
Just one point on that. We actually, we have access to these ear dryers now, commercial ear dryers for surfers and swimmers, and they're actually rather effective, to the point where we don't recommend earplugs anymore. They go swimming, and they just dry the ear.
Which dryer is it? I've not heard of this.
There are a number of brands. The Max.
So an ear dryer is what you would look for?
It's a little blow dryer. You put it up to your ear, you push the button, it blows for 60 to 90 seconds and warm air, and they take it with them to the pool. So it's been very helpful.
Okay, interesting. Can you get a 2-year-old to do that?
Yes, some like it, some don't, but it's not as noisy as a hair dryer. So yeah, our patients do like those. But so I still, for the pediatric patients, particularly if they have a partial effusion, I don't do anything. But if they've got mucoid effusion, I'm tending to put in a grommet, but not a ordinary size grommet. I'll use a sub-millimeter grommet that's intended to fall out relatively quickly. So I still lean toward that, because I've been shy about possibly having to do a repeat procedure if you've got a thick mucoid effusion. But I'm curious about the experience of the three of you. With mucoid effusions in pediatric cases, are you getting away without a grommet?
I'll let you guys speak, and I'll tell you what
Well, if you do balloon dilation, yes, then you don't need a grommet. So in our cases, so we used to do both balloon and a grommet, but it's slowly shifting in my practice anyway to just doing the balloon and leave the tympanic membrane.
Wow.
But if you go to a local practitioner in Denmark, they will put in a grommet very quickly.
Right.
Typically also a long-term grommet. So the new grommets is called bobbin grommets. It's a hard silicone plastic grommet, quite large, with a so it will stay for at least a year in the tympanic membrane. So that's why we have the high case of perforations, I think.
Mm-hmm.
But there's still a huge place for grommets, I think.
Oh, absolutely.
And it's a balloon dilation is not going to actually click insertion, but you need to tailor that, and you need to consider the specific patient. And if there is a strong desire for swimming and outdoor activities, I think it's much better to go for a balloon. But it's still, we need data on that. We need the randomized controlled study. There's a lot of evidence now that it may be beneficial, but we still need definite evidence for that.
Working.
Yeah.
So I would say that in my practice, I've kept, at least retrospectively, looked at it, and I use grommets more in patchless patients that I've blocked up with a shim than I do in regular patients. What I do though is if it's just a general effusion and it's really less than 20 decibels of hearing loss, always just a balloon. If it's getting more to that 40 decibels and it's been there a long time and it really is likely to be a glue ear, I will do an 18 gauge needle. So basically a spinal needle is a suction, and I'll make a very small myringotomy and suction that out to basically jumpstart it all. But I don't put a grommet in afterwards. I just relieve the thick effusion so it doesn't allow it to block up from below. And I've not had, my numbers haven't changed from when I was using grommets. In fact, they probably gotten better.
Okay, you've published that the full benefit, clinical benefit from a balloon dilation is usually about, I think you've published about 4 to 6 weeks before all of the tissue swelling goes down. And there have been animal studies that have corroborated that almost identically in rats and mini pigs. So what do you tell the parents if they're not getting a grommet? How long will it take for the effusion to relieve?
Well, when it comes to them, I generally inform them that they have to wait for a couple of weeks to see the final outcome, so they shouldn't be disappointed, and ask them to wait for a Valsalva maneuver for at least 3 days before they start doing that. Because initially there are 2 groups of patients, one that will do fine in the recovery room and say, well, I can do Valsalva and everything is improving instantly. But there is another group, which probably is the majority, where the mucosa needs to heal. When you have done this really nice experiments looking at the histopathology of healing, so you shear off the biofilm, you get rid of a deadlock situation in terms of a glue eustachian tube, and then the clearance takes a while, and the mucosal lining needs to heal over time, and so that is generally taking some weeks to heal properly.
I would say that I think that's actually a really good point just in general for counseling patients. Whenever I'm giving them the 2 options, and I always provide both options for the patients, is tube versus a balloon, is that the tube makes it better immediately. The balloon, you may notice some positive benefits, but you're absolutely going to have ups and downs. You're going to need to be Valsalving, and there's a chance that when you come in at 6 weeks, we may have to be more aggressive with anti-inflammatories, things like that, to really get it to clear. But in general, I think that as long as you explain it beforehand, I've not really had much issues with families being upset. Again, if they're coming in for a hearing loss, especially a pediatric for a failed test, that's when I do that myringotomy to clear it right away, just so they do notice a difference. So, what do you think is the future, for what we would need to kind of really, I mean, we've talked about things like, figuring out the proper techniques, times, whether you do a tube or not, but where really is future innovation, future possible treatments, or are there any needed? Is this good enough? I mean, that's really 80-90% success is not indicates it's a pretty effective thing. I mean, I think that 10% a lot of times is going to be that bony isthmus. So like, doing otoendoscopy or doing things from the eustachian tube to be able to clear that maybe safely, whether you do from the nose or the ear, maybe a something that would be, I think, valuable to get that extra 10%.
It could be also that we've been talking about today that the endoscopic procedures are getting smaller and smaller and smaller with the tiny cameras. So it may be possible to actually visualize the bony isthmus and look directly into the bony isthmus and see if that is the issue or not. So maybe Hope can talk a little bit more.
We currently developed an endoscope with 0.8 millimeters diameter. And we're actually able to do that and visualize the eustachian tube, not only in the cartilaginous portion, but also in the bony portion. And this will give us, I think, a major step forward that we are really able to visualize the underlying pathology. It's really amazing because you can do a Valsalva maneuver with the endoscope within the eustachian tube. You can see the air bubbles traveling. And I think this is giving us a much better insight into the underlying pathology. And I think there is, apart from working on proper eustachian tube tests, which we still are required, I think there is no doubt about that. We are on a learning curve. We are able now to distinguish between papious and blocked eustachian tubes. And we have been learning much more about eustachian tube physiology over the time. And I think there is still room for a lot of improvement. Think about if we would guess that about 7% papious eustachian tubes in the Japanese population, which has just been published. How is that established? What happens? Is there a papious eustachian tube in children? So I think there's a lot of things we can still investigate and which are options for the future.
I think also that we need to teach the general ENT physicians about making the correct diagnosis and then choosing the correct treatment. So I still see a lot of colleagues that are not treating patients within the new guidelines, I think. So there's a lack of education. So we need to get out there and teach people how to do this.
Well, I think if you think about it, it's such a hard thing because all of the symptoms are in the ear. But all of the pathologies in the nose. And for the last 50 years, there's been a stronger and stronger separation between otology and rhinology. So there really is all of the diagnostic skill and training is really on the neurotology side, whereas all of the technique and surgical skill lies on the rhinology side. And it is, and most general practitioners just don't want these people around anyway because they're complaining all the time. And so they send them to the neurologist or they send them to the rhinologist. And so coming up with training programs, I think, and understanding it. But, one of the things that I think is underappreciated, and even after doing this for 15 years, I'm just now, I think, beginning to understand it is, Dennis always described the muscular dysfunction. And I think you put it at 8% in one of your slides a long time ago. And I remember looking at this and going, I don't know what he's talking about. I looked at those things forever, opening and closing. And it just kind of like your slow motion when there was that epiphany of, oh, it's a valve and closing. There was just one day I was looking at patients, it was probably about 3 or 4 years ago. And all of a sudden you could see the disorder in the muscular function. The muscles were moving not in the right connection. Those don't respond to dilation. Those are not necessarily, there's no inflammatory pathology. So started using Botox and some of those, trying to reset those muscles, looking at the innervation of those muscles. And I think there's going to be, as you get rid of 80, 90% of the inflammatory burden, there's still going to be a population that has a eustachian tube dysfunction, but it's more going to be a neuromuscular dysfunction. And how do you fix those? What is the right path, and how does that popping and clicking, a lot of those things that people have that aren't really an actual eustachian tube problem, but it's more of a sound transfer into the ear that bothers them.
Well, you have to start out with doing an endoscopy and look at the actual eustachian tube. So I think still a lot of trained neurotologists and so forth are not looking in the nose.
No, I don't think they have any desire. I mean, not even in anterior rhinoscopy. They don't even want to.
No, this is a new field. People are uncomfortable in this area, in the majority. And the Eustachian tube was just blamed for all sorts of ear fullness when you didn't have a visible explanation. It must be a Eustachian tube dysfunction. So there's a great deal of education, as you're saying, that's necessary in learning how to make the diagnosis and appreciate the courses that you're doing, like right now, how to properly evaluate it. It's actually not difficult. It's just proper orientation of the endoscope and some careful observation. It's no more difficult than looking at the larynx. In fact, it's probably a little easier. You don't have to make a right angle turn. But it's just adapting to this new discipline. So learning how to make the proper diagnosis, and it's great that we now have treatments. So much more needs to be done in terms of the research into the pathophysiology, and then into the mechanisms of our treatments, how they're really working, and then clinical trials, as we've talked about. How are we going to assess our outcomes? And from there, we can build on this further research. So, Helga, it's exciting. You're going back to the microendoscopes, but with much better views than we've had in the past. I'm sure you're going to be able to get some working instruments up there for providing drugs or a laser or other technology. That'll give us access higher into the cartilaginous portion, into the isthmus, into the bony portion safely. So there's a bright future for minimally invasive treatments getting ever higher. And I think the biggest contribution is going to be in other medical means of treating the inflammation. We now recognize it's mostly inflammation. There's lots of medical ways of treating inflammation if we can get the drugs to the target. And so I think that's going to be a lot of innovation from that point of view, both from the ear, from the nose. There's been some exciting work from a couple of groups, Kirshner in Wisconsin, Kohani here at Children's. They have topical drops with nanoparticles or chemical permeators. It'll take a payload, currently antibiotic, right through an intact tympanic membrane. Once you get in the middle ear, gravity and the mucociliary flow is going to take your compound right down into the Eustachian tube.
But how long would it stay?
How long would it stay? Well,
yeah, I mean, like if it's got to travel that far before you get to the area of treatment, with that, I mean, you would have to have something that would, for some reason, you'd want it to slow down in the actual orifice, wouldn't you?
Well, but if you can do it topically, you can do them repeatedly, just like we do with topical ear drops. And of course, you could do a myringotomy and put a slow releasing device into the middle ear. And people are working on stents to go up into the Eustachian tube with drug release. Injections are being proposed. Remember, we don't want to inject particulates. They've done that to the turbinates. There were retinal vein occlusions and blindness. We're not injecting particulates, but other compounds. I think there's a big future for slow release devices and how to get them to these locations.
And what we see on the other hand, looking at Th2 reactions in chronic rhinosinusitis, the use of biologics is going to change the outcome of Eustachian tube dysfunction as well. So what I've seen in a lot of patients with chronic rhinosinusitis, the Eustachian tube dysfunction improved significantly. If you look at interleukin 4, interleukin 13, or alarmin TSLP inhibitors, they will play, I think, a major role as well. There's a medical option blocking chronic infection, and probably doesn't have a disease modulating effect, but at least is going to clear symptoms while you apply biologics to chronic Eustachian tube dysfunction. So apart from a topical treatment, I think systemic treatment will have its value on its own as well in order to improve Eustachian tube dysfunction.
Yeah, I agree. As surgeons, we are a limited people.
Yeah.
Dying people.
Yeah, no, medicines are definitely I think a lot of it will be more targeted therapies for all of it. And I guess the other big thing that is not in Dilation tube dysfunction, but because again, we can now recognize it and fix it. I think I cannot tell you most of the patients that get sent to me for a balloon dilation actually have patulous. And it's because they put a tube in the person and they got better, that they're not going to send them to me. But they'll send the one that had a tube and didn't get better, and they think it's a station tube dysfunction. So being able to not only recognize patulous, but having easier ways to fix and address that is going to be, I think, important.
Yeah. Again, teaching, education. Yeah, it's a massive need.
Yeah,
I would say.
Well, I think our time is about up. So I'd like to thank everybody. Dennis, thanks for joining us from Boston. We're sad you're not here because of the weather, but it is glad that you could be with us today. Holger from Germany, I'm sorry that you might miss your flight. It's the one thing Dennis was afraid of. So they actually just rescheduled his flight. So the one thing you were worried about is he may not get there till Monday. And then Mark Moyer from Denmark. And I mean, all of you guys, I've learned something from each one of you guys. And it's been really fun over the last 10 years to be able to see how, you know, from the first couple of kids we've been able to help to, or adults that, you know, that are just desperate to change their life, to like now it just becoming an accepted and normal practice. It's pretty cool to see where it's going to go. So I really do thank all of you.
Yeah,
I want to thank all of you.
Nice to see that we can help more patients. Minimal invasive procedures, helping more patients is what we do.
And there's still room for innovation. So, and I'd also like to thank the International College of Surgeons for hosting this for us. And so you can visit their website at right there, www.ficsonline.org.
Thank you so much.
Thanks, guys.
Thank you, guys.
Thank
Thank
you.
you, everyone. It's been a privilege to work with you.
You as well. Very much so. It's really been fun with all you guys. Like,